When I was a resident, I enjoyed the cancer surgery that colorectal surgery afforded. I thought the pelvic anatomy was fascinating, and so it just fit. I talked to the patient and, of course, interview the patient, their past medical history. Most of that is already in the medical record, and I've reviewed that. I look at the films. Oftentimes I'll review those films with the patient, CAT scans or x-rays. We talk about everything we're doing and the plan, and give the patient a chance to ask questions and to satisfy them. I look at my job as not really telling the patient what to do, but giving the patient options. It depends on the patient, depends on their personality, it depends on what they want in their care. The patient always has autonomy. So I view my role as an educator, as a guide, and as a person that they can come to and they can confide and they ask questions. The most rewarding part is twofold. One is relieving pain. So if someone comes in with an anal fissure or fistula or anal cancer, and you can treat it and you can relieve that pain, that's, I think, credible. And then the other thing is prolonging life. I follow my cancer patients that I've resected long term. So I'll have patients come in my office for the yearly checkup, 10 years after having their cancer resected, and to see them doing well, to hear about their grandkids, to hear about, that they've had for 10 years additional life that has been pain-free and also a cure. It's very, very rewarding. I've been involved with patient blood management for a long time, so I have a large number of Jehovah's Witness patients, or patients that refuse blood products, and we keep that in mind. And even though we may delay the surgery to build up their hemoglobin hematocrit, it's very important that they go in with that assurance that they aren't going to have problems.